Welcome to Nexus Medical Media. If this is your first time, uh, thank you so much. Don't leave without leaving your subscription here. Right. So I just want to take this opportunity to let you know that for those who are asking how to buy me a coffee, now you can just check the description box, and you can find your way to buy me a coffee. Right. So in this video, we'll be talking about a fungal infection that leads to cryptococcal meningitis. Right. That specific one is called Cryptococcus neoformans. Right. So Cryptococcus in general, we talk about two medically important species complex: Cryptococcus neoformans and Cryptococcus grati. Right. So, but I won't talk much about this one because it is not the most common cause. And just fun fact: this one is found in barks of eucalyptus trees. That's where it is mostly found, in regions where it's prevalent, right? But here we'll talk about Cryptococcus neoformans. Here there are species and serotypes and lineages. Well, these are beyond this presentation, right? So if we talk about cryptococcal meningitis caused by cryptococcal neoformans, we need to remember four things, right? So you need to think of a patient who is immunocompromised, a patient who had at some point uh, contact with pigeons, and meningitis, or let me call it meningoencephalitis. I'll explain why that is, and then just to remember the Indian ink, right? So this tetrad is very important. Just if you keep this in your mind, you will remember a lot of stuff concerning this topic, right? So let's talk about the pathogenesis. So remember, I said the pigeon, right? So pigeon droppings, that's where you actually find the what? The spores of cryptococcal neoformans, and then the route of transmission is through inhalation. So you inhale the spores, and then the spores will find their way to the lungs, and there they will change to yeast, right? So that yeast will actually proliferate there, causing local lung infection. But that is asymptomatic, unlike other fungi which cause respiratory infections like histoplasmosis, coccidioidomycosis. Just to click the link on the top right corner, or even better, check in the description box where I have links to different videos when we talk about these fungal infections. Right. So let's proceed. You have the local infection in the lung, but it's not symptomatic. Right. Then it will find its way to the brain, right? It's a hematogenous spread. So in the brain, this will cause a condition known as meningoencephalitis, right? Because most people call it meningitis, but to be honest, it also causes the inflammation of the brain itself. So meningoencephalitis is the new term. Right. So talking about the epidemiology, majority of individuals with cryptococcosis are immunocompromised. Right. So here is a list of conditions which can cause you to be immunocompromised, but in order. Right. So this is like from the most common: AIDS patients, and then also think of prolonged treatment with glucocorticoids that could cause immunosuppression, organ transplantation recipients because they are on long-term corticosteroids, malignancy, liver disease, sarcoidosis. But the most common is AIDS, right? AIDS is the most common, right? So the vast majority, over 90% of the cases of cryptococcal meningoencephalitis are seen among AIDS patients with a CD4 count less than 100 cells per microliter, right? So who do you see presenting with this condition? An art naive patient, someone who was never on art, right? It's the new diagnosis. Then the patient will come with features which I will talk about later, right? So the other way is when the patient is already on ART, but there is a drug resistance. And the third way is when someone is on ART, there is no drug resistance, but poor adherence to the medication, right? So all these three could be the reasons why an HIV patient could present with cryptococcal meningoencephalitis, right? So talking about the symptoms of cryptococcal meningoencephalitis typically begin indolently over a period of 1 to 2 weeks. And the most common symptoms are fever, malaise, and headache. And also there is a stiff neck, a photophobia. The person doesn't want to go outside where there is light. And there's also vomiting, right? So these are seen in 1/4 to 1/3 of the patients, right? Occasionally, patients can present with coma and fulminant deaths in days, right? So it actually kills if you don't intervene. And the symptoms suggesting a disseminated disease include a cough, dyspnea, and skin rash. There could also be a visual and hearing loss. Here I just classified the symptoms into meningeal and non-meningeal, right? So the most common is headache. There's also confusion in 30 to 40% of the cases, behavioral change, nausea and vomiting, especially early in the morning. That could actually relieve the headache. There could also be seizures, double vision, visual loss, and hearing loss. Non-meningeal symptoms include a generalized body weakness, a loss of weight, cough, chills. These are more like B symptoms, fever, and skin rash or skin lesion, right? So I actually have a picture of the kind of skin rash I will show you next. But here on physical examination, the initial physical examination may be notable for lethargy or confusion in association with fever. In one study that was published, 24% of the patient had altered mental status on presentation, and about 6% had focal neurologic deficits, such as cranial neuropathies. You know, the most common cranial nerve affected is cranial nerve number 6, abducens, right? But that is actually a false focalizing sign, right? So that the neuropathy is happening because the sixth cranial nerve is the longest course intracranially. That's why it's first to be affected by increase in intracranial pressure, right? Other manifestations of disseminated disease may be evident, including tachypnea, skin lesions which resemble molluscum contagiosum, and increased diastolic hypertension may be reflective of increased intracranial pressure, right? So here is the typical rash, right? So you can see this is called umbilicated, right? So you will see multiple umbilicated papules which are seen on the especially on the face, right? So they are called the cryptococcomas. Cryptococcomas, right? It's a sign of a disseminated condition, right? So you have taken your history, you have examined your patient. The next thing you need to think about is the investigation, right? So you need to have a high index of suspicion for crypto, right? So here in patient who is presenting it first time, or someone who has HIV but the CD count is below 100 micromole, 100 cells per microliters, right? So the initial evaluation will include a careful history, neurologic examination, and serum cryptococcal antigen, serum Craig. Evaluation should also include a lumbar puncture to assess for increased intracranial pressure, right? So you see high opening pressure, right? So that will lead you to suspect that this could actually be what? A crypto. Right. So cryptococcal antigen, right? So this can actually be detected in the serum and cerebrospinal fluid. You can use a method like immunodiagnostic techniques such as latex agglutination or sandwich ELISA, enzyme-linked immunosorbent assay. You can also use a lateral flow assay, right? So this one is actually an alternative. It's simple dipstick test that is inexpensive and it's used even in like poor resource countries, right? So you can use it if you on the blood sample or cerebrospinal fluid. And most of these methods, of course, if you are working in the lab, you need to know like how it's done. But as for you being the doctor, you just send a sample and you get the results, right? So there is a lumbar puncture. That one is important, right? So a lumbar puncture is required to obtain cerebrospinal fluid for confirmatory testing to make the diagnosis of cryptococcal meningitis. And the cerebrospinal fluid profile, okay, I will show you like the sample. If someone has a fungal infection, what would the biochemistry show, right? For example, the cells could actually be below 50 cells per microliter with mononuclear predominance, and the proteins may be normal or slightly elevated, while glucose concentration are commonly low or normal. And also, a lumbar puncture is important for determining the patient's intracranial pressure, the opening pressure, which I mentioned. Right, so if it's high, that one could also help you determine the significance or the morbidity or the mortality risk, right? So this is how a lumbar puncture is done. But I left this slide open. I would like to know a list of contraindications to a lumbar puncture. So just in the comment section, just run down the most important contraindications, or you can divide your contraindications to uh, absolute or relative contraindications, right? So I'm waiting for that one. So this is a typical presentation, right? So this table is just showing you the biochemistry of lumbar puncture in case of viral infection, bacterial, fungal, and TB. And if you look here, the opening pressure will be normal or high, right? High in most cases. So you can see the normal opening pressure is 4 to 18 centimeters of water. Here, it could be as high as 250. Wow, this is insane. And then the white blood cells, usually less than 50 cubic millimeters per microliter. And on the differential, usually monocytes, and glucose, usually low. Sometimes you may find it normal, but low. And then the protein will be high, and there will be no red blood cells there, right? So, okay. Next one is cryptococcal polymerase chain reaction, right? So there is biofire and film array. Well, these ones are expensive, but they can also be done, right? Uh, so in one study in Africa, this test detected cryptococcus in the cerebrospinal fluid of patients diagnosed with a first episode of crypto with over 90% sensitivity and excellent specificity, right? So what's happening in this case is it depends with the level of the crypto, right? So sometimes the Craig may not actually test a positive, but if you use this one is excellent sensitivity, right? And PCR was particularly helpful to distinguish persistent culture positive relapse from paradoxical iris. There are two types of iris, right? The other one is called unmasking. The other one is called relapsing. So you need to know the differences. Just in the comment section, we need active learners, right? And then there is Indian ink, right? So this one is very important. You know the basics. Cryptococcal meningitis, cryptococcal neoformans. I mean, the fungi has a thick capsule, right? So you can use the Indian ink to demonstrate this encapsulated yeast, right? So in about 60% of the cases, it would actually be positive. However, Indian ink can miss low burden infections, right? For example, in one report, the sensitivity of India ink was only 42% when the culture burden was less than 100 colon forming units per mil, right? So as I mentioned previously on biofire, so if it's less than 100, the sensitivity you can see it's low, it's 42%. But if there are more colon forming units, let's just say 3,000 going up, you can see that the Indian ink will be picking that up. But if it's low, that's where if you still suspect that the patient could actually have a crypto, you need to do biofile. This is what it looks like on India ink, right? So you can see this is the cytoplasm and the granules, and see this is the cell wall, and then this is the capsule. All right. Going on, there is a culture. Well, culture is rarely done, right? But whenever you take the cerebral spinal fluid, the sample should be sent for culture, and you can see cream-colored mucoid colonies on agar plates. So the results will come in 3 to 7 days, and there is a specific agar that you use. It's called suborand agar, right? So you can see this will be the culture results, right? But this is for a clinical microbiologist. We probably won't see anything like this if you are staying in the hospital most of your time, right? So you need to go to the labs and see these things. Then there is magnetic resonance imaging. This is rarely done, to be honest. But in general, if someone has come with focalizing signs, you are suspecting crypto, but has focalizing signs, that would warrant you to do a scan. You can do a CT scan to exclude the space-occupying lesions, for example, because that would be contraindication to a lumbar puncture. That could lead to herniation, etc. Right? But MRI is more sensitive compared to what, to a CT scan, and in the case of crypto, you can actually see something on an MRI, although it's rarely done. Right, so the sign is called soap bubble appearance, shown by the arrows here, here, and here. Right? Wow. This needs a radiologist. I just included this, but for you to know, for example, you can get an MCQ. What does it look like? These are called gelatinous pseudocysts or soap bubble appearance. That's it. Then to conclude this video, we'll talk about the complications, right? So the first complication is persistent infection, right? So let's say the patient tested positive, and 4 weeks you are in treatment, but it's not the patient is not getting better, or the results are still positive. So that would be a persistent infection. A relapsed infection, right? So this is based upon two main characteristics. First, you have tested it, you find it is positive, then you treat, and then you find that the body is sterile. When you try to do all those investigations that I mentioned, you find that the patient is sterile, right? There is nothing, or the symptoms and signs at a previous site of the disease will support the presence of the disease after you have concluded that it's not there. All right, so that would be a relapse. And then elevated cerebral spinal fluid pressure is next complication, right? So acute elevated symptomatic CSF pressure, sometimes due to initial antifungal therapy, should be managed rapidly by decompression via repeated lumbar taps and transitory lumbar drainage catheter or ventriculostomy in some patients, right? So this is just management of CSF, high intracranial pressure, I mean. And then there is iris. Well, I asked you a question before. So unmasking iris is when the cryptococcal symptoms appear after the initiation of ART. Paradoxical iris. This occurs during the treatment of cryptococcosis and administration of ART, right? So that is. And then next is cerebral cryptococcomas, right? So this can actually occur and cause significant short and long-term neurological complications. They are hard to treat, and these would normally require a long-term antifungal therapy. Last but not least is hydrocephalus, right? So this is a later complication and can present as dementia or chronic headache, right? So the complications, just one more time, you could get persistent infection, relapsed infection, elevated intracranial pressure, immune reconstitution inflammatory syndrome iris with these types, and cerebral cryptococcomas, and not forgetting hydrocephalus. Right, so the next video will be talking about how you treat this patient. So stay tuned, and if you watched for this long, thank you so much for watching.